got a couple of cases to run through, and I'll ask the panel to come on, and we can perhaps ask some questions of each other that may have come up during the presentations. John, Dr. Sperling, one of the questions that someone had typed in is when you send pathology to the lab, they often come back and say arthroplasty effect, and how much weight do you carry, and Joaquin, you can answer this question too, for the white blood cells per high power field. Is that how important is that for you in your practice?
Yeah, Scott, it's a great question. I try to put it all together in regard to the clinical appearance, the history. Was there a history of wound healing problems? Is the humeral component loose? Is there early glenoid component loosening? And then based on the appearance there, so I let it play one aspect. But I will say I place more emphasis if the pathologist comes back and says there are signs of acute inflammation. There's more emphasis for me than if they just said that there's no acute inflammation. Joaquin, what are your thoughts on this?
Yeah, very similar. It's important to realize also that Proteobacterium acnes generates chronic inflammation. So when we have talked about the topic with infectious disease doctors, what they recommend to us in pathology is look for a combination of acute and chronic inflammation. So that may be important too.
Thank you, guys. There was a question from the audience on the very obese patient, and I think us at Mayo call it the double axillary sign, where you get an AP view and it looks like an axillary because the arm's out to the side. Is there a limit or any thoughts on obesity and other than a larger glenosphere, maybe a lateralized design? Maybe I'll ask Tom your question. What's your approach? We have heavy, fluffy people here in Minnesota, but I'm sure all the svelte people in Florida maybe don't have this problem.
We've got our what I call carbohydrate poisoned people, and you know, the funny thing is, I think that with obese patients, we haven't seen a major instability issue with them. But I think using a lateralized design either on the humeral or glenosphere side helps you, because what they have is a built-in abduction pillow. And I think on the medial designs, like the old Vermont, the fat is pushing them out. But if you got a lateralized design, you got a built-in abduction pillow, and we haven't really seen a lot of instability. It's not like I really love operating on them, although a lot of times the fat just falls away a little bit. But in any case, I don't consider it a contraindication.
If I can comment briefly, I would just say that, you know, there's the whale fat and the bear fat. The whale fat's easy because it falls open and you can get easy exposure and put your components where you want. The bear fat's a very muscular, kind of big, high BMI person, and it's a lot harder to get your exposure and put your components in the right position. But I agree with Tom as far as kind of your built-in abduction pillow if you get them in. Obviously, their associated potential comorbidities are a concern, and you know, I think we got to be careful how high a BMI we go in the postoperative period as far as the complications they incur.
Maybe I'll show one case to wrap things up, and then maybe we'll have a final question or two. There's a case of a 90-year-old female. We do operate on some older people. They live maybe a little bit longer in the cold up here, and even get that going the right way. Oop. It's going awful fast. Well, why don't we pull that back? Why don't we start here? Oh, maybe stop moving the. See if I can get this to come back. So hopefully it'll stay right there for a second. So there's a fellow, nice fellow, had this older near metal back designing for many years, and you can see came in. You can see the picture on the right, where the glenoid component is not in bone, and there's not much bone left. And let's see if this will actually show. You can see the implant out anteriorly there. And what are your thoughts? Perhaps maybe I'll ask Joe, since you're talking about bone bone loss. So when you have a significant bone loss, such as in this patient, what do you do to try and recapture, or do you go to a hemi right away, or do you have any techniques to?
Yeah, so I mean, in a case like this, if obviously a 90-year-old, you said, is going to have poor bone stock, one surgery is ideal, but if I don't think I can get a stable base plate in one surgery, then I'll bone graft them. Sometimes I'll put in if I think there's any signs of infection, I'll put in a spacer. Sometimes I'll leave them with a resection arthroplasty for 3 months, come back, and then do a reverse. If I can use the alternate center line and invert my glenosphere using a screw-in central base plate, then I'll try to do that, potentially utilize some allograft. But always a concern that they may potentially loosen prematurely or rapidly post-op or dislocate.
And John, you've used some of the computerized navigation designs. What is that something you would consider using in this situation potentially?
I think you can consider it. I'm concerned about this one because you can see that it looks like if the whole anterior wall is gone from what I think I saw. So the challenge with that is I think that's tough to manage. In my experience, posterior wall being gone is a little easier than anterior wall being gone. And at that age, if I couldn't, my goal would be at least to get 50%, 40% contact with native bone in that patient. If I couldn't, I consider bone grafting it. But 40%, 50%, I would try to get a base plate on there, as Joe mentioned, and try to move forward.
And we followed Joe's advice, and we got about maybe 30, 40%. You can see the picture on the right X-ray. It's kind of right down the pike. Only room for a screw above and below. And we're fairly happy with that. But then 5 weeks later, he says there's something clicking in my shoulder. So he's got a glenosphere on the loose. And Tom, you were talking about fractures. What should we do now?
Well, I mean, yeah, I think now you're probably going to take everything out. And for me, I would have done this the first thing because the guy's 90, and I don't ever want to operate on him a second time. So I probably would have pulled everything out to begin with, used non-structural allograft mixed with antibiotic, and put in I use an interspace. Basically, it's antibiotic hemiarthroplasty. So basically, I put in hemiarthroplasty with antibiotics and go home because I really don't want to have to do a 2-stage procedure on this guy. Now, if he had that deformity, and he was in his 60s or a really young guy, I think doing a 2-stage, and I've done that, probably almost once a year, where you bone graft to put your base plate on, glenosphere, and don't connect the two, and then come back later after, 4 to 6 months later and connect the two. That can work, but I wouldn't do that in a 90-year-old.
Yeah, the slides actually got mixed up. He's about 65. I'm sorry, I had to run back through that, but I agree. So what we did is went ahead and took it out, put a large head hemi in, and he actually did well. He's actually went down to Florida for the winter time, and when he came back, he actually had surprisingly good motion, 125 degrees, and external only neutral, as you can imagine, but doing well pain-wise. I think we'll just stop with that case, and so we can finish on time. I want to thank all the panelists. I thought those are all excellent talks. I want to thank all the participants, and we had over 500 people registered for this course. So again, I want to thank all the attendees. I want to thank the faculty, and I want to hand it back to Corey for the final comment.